Good evening to all. In this video, we are going to see about ectopic pregnancy. I am S. Ruth Kesia, working as a tutor in Triple College of Nursing. The objectives of this video are introduction about the ectopic pregnancy, definition, size of implantation, tubal pregnancy and its types and management, abdominal pregnancy and its types and management, ovarian pregnancy, cornal pregnancy, cervical pregnancy, and heterotopic pregnancy. So these are the subtopics we are going to see under ectopic pregnancy in this video. Introduction. Ectopic pregnancy is the leading cause of maternal death in early pregnancy. It accounts for about 3.5 to 7.1 percentage of maternal deaths in India. The incidence of ectopic pregnancy among all pregnancies is about 0.25 to 2.0% worldwide and can occur in any sexually active woman of reproductive age. Ectopic pregnancy was reported in 0.91% of pregnant women with no maternal deaths in a study done at a tertiary care center in South India. It can be life-threatening and needs to be treated as medical emergency. So ectopic pregnancy is one in where the implantation occurs at a site other than the uterine cavity. So that's called ectopic pregnancy. The sites can be uterine tube, ovaries, cervix, and abdomen, etc. Definition: ectopic pregnancy is one in which the fertilized ovum is implanted and developed outside the normal endometrial cavity. So the implantation has to occur into the endometrial cavity of the uterus. So there are three layers in the uterus: perimetrium, myometrium, and the endometrium from out to in. Okay, so the inner layer, the innermost layer is the endometrial layer. So in that layer only the fertilized ovum supposed to get implanted. So if it gets implanted other than that site, any area in the reproductive organs, then it is called as ectopic pregnancy. So the sites of implantation can be as you see in the picture, it can be interstitial, it can be cervical or intramural or into the ovary or abdominal or ovarian or infundibular or fallopian tube or the ampullar tube, the intraligamentous site and isthmic site. So these are the various sites of implantation. So, but most of all the site, the most commonly occurring ectopic pregnancy site is the fallopian tube. Okay. So first we are going to see about the tubal pregnancy. We'll see the all types of pregnancy one by one. The first is the tubal pregnancy, that is the pregnancy occurring into the fallopian tube. A pregnancy that is not in the usual place within the uterus but is located in the fallopian tube. Tubal pregnancies are due to the inability of the fertilized egg to make its way through the fallopian tube into the uterus. So that is why the implantation occurs in the fallopian tube. So the fertilized egg couldn't able to reach the endometrium. So it gets implanted into the tube itself. As you see in the picture, the fallopian tube uh, implantation, the tubal pregnancies, as you say, it is account about 95 to 96 percentage of ectopic pregnancy. So it includes interstitial, isthmic, ampullary. Okay, all this includes the fallopian tube implantation. So the etiology can be because of the adhesions. So as you see in the picture, the white fiber-like structures are called the adhesions. Okay, the first ring shows the adhesion between the uterus and the cornual region of the fallopian tube. Then the second ring shows the fallopian tube and the ovary and the fimbrial end. The third shows the ovary to the fimbrial end. Okay, so if it all get plastered together, so then there won't be free movement of the implanted fertilized egg into the fallopian tube. So that's why the implantation occurs outside the endometrial cavity. So to understand about the causes, you need to understand the normal anatomy of the fallopian tube. So there will be ciliated lining into the fallopian tube and there will be peristaltic action of the fallopian tube. These two are very, very important for the transporting of the fertilized gamete into the endometrial cavity. So any alteration in the normal function of the uterine tube in transporting the gamete contributes to the risk of tubal pregnancy. The reasons can be because of congenital abnormalities of the tube such as hypoplasia, undue toxicity and tubal diverticula. And the second will be previous infections such as post-abortal sepsis, puerperal sepsis, gonorrhea and tuberculosis. And there can also be an alteration in the anatomical normal anatomy can also be due to surgeries in the uterine tube like reconstructive surgery for infertility or reversal of tubal ligation, or it can be due to use of intrauterine contraceptive devices. So these devices will protect the intrauterine pregnancy but not from tubal pregnancy. And also it can occur because of assisted reproductive techniques like in vitro fertilization and embryo transfer. The transferred embryo may get injected into the tube, so that may be one cause. And this tubal pregnancy can also occur because of induction of ovulation with gonadotropic hormones and also because of endometriosis. So these are some of the reasons of known causes why the ectopic pregnancy occurs into the fallopian tube. So this is the normal anatomy. So the white fibrous layer, as you see in the previous picture, it's shown a big one here. See the blockage in the tube. So that is the blockage into the fallopian tube. So the risk factors are history of pelvic inflammatory diseases, history of tubal ligation. So as I said earlier, everything is given here. Contraception failure, previous ectopic pregnancy, tubal reconstructive surgery, history of infertility, previous induced abortion, tubal endometriosis. So these are some of the risk factors of ectopic pregnancy. So what happens in the ectopic pregnancy? Changes in the tube, there will be changes in the tube and there will be changes in the uterus. So as I said earlier, the changes in the tube may be like the ciliated lining into the tube may be changed, and the peristaltic action of the tube may get altered because of the surgeries or because of the intrauterine contraceptive devices, or it may be altered changes into the uterine cavity may be because of congenital anomalies or previous infections. So all these can contribute to the risk factors and can cause the ectopic pregnancy. So the next type of ectopic pregnancy, they are acute, unruptured and subacute. Clinical features. In acute, we have abdominal pain. There the mother will have abdominal pain, vaginal bleeding, amenorrhea, shoulder tip pain, vomiting, syncopal attack. Signs will, the patient will look, general look will be blanched, paler. Features of shock like pulse rapid and feeble, hypotension, extremities cold and clammy. So next is the diagnosis. So the abdominal examination reveals the lower abdomen is tense, tumid, tender. No mass is usually felt. Shifting dullness present. Bowels may be distended. Muscle guard usually absent. In pelvic examination, the findings will be vaginal mucosa will blanched white. Uterus seems normal in size or slightly bulky. Extreme tenderness on the fornix palpation or movement of the cervix. No mass is felt through the fornix. The uterus floats as if in water. Clinical features in case of a next is unruptured pregnancy. So previously we saw the acute type. The next is unruptured. Presence of delayed period or spotting and uneasiness on one side of the flank. Diagnosis will be bimanual examination shows uterus is usually soft, showing evidence of early pregnancy, a pulsatile mass, well circumscribed tender mass may be felt through one fornix separated from the uterus. So when we do a bimanual means one hand through the vagina and one hand will be placed on the abdomen, okay, over the symphysis pubis, then you will be the results will be the uterus will be soft, showing evidence of early pregnancy. Pulsatile mass will be present and it will be tender and can be felt through one fornix separated from the uterus. Transvaginal and sonography can be done. Highly sensitive radioimmunoassay of beta HCG can be done, and laparoscopy. All this will reveal ectopic pregnancy. Clinical feature for subacute. The third type is subacute. The patient will have amenorrhea, lower abdominal pain, vaginal bleeding, bladder irrigation and irritation, rectal tenesmus, rise of temperature. All this will be present in case of subacute type of unruptured ectopic pregnancy, that is the unruptured type of tubal pregnancy. On examination, the patient looks ill, pallor varying degree is present, pulse persistently high, temperature may be slightly elevated to 38 degrees Celsius, tenderness will present. A mass in the lower abdomen may be felt which is irregular and tender, which is called as Cullen sign. Vaginal mucosa will be pale, uterus seems to be normal in size or bulky, extreme tenderness on movement of the cervix, an ill-defined, boggy and extremely tender mass is felt through the posterior lateral fornix extending to the pouch of Douglas. The mass may push the uterus to the opposite side. So these are the findings on will be felt on examination. The differential diagnosis. So we can wrongly diagnose like the patient may have acute appendicitis, ruptured corpus luteum, twisted ovarian tumor, ruptured chocolate cyst, perforated pelvic ulcer. How to correctly diagnose, how to confirm the diagnosis is by checking the serum beta HCG level, transvaginal ultrasonography, color flow Doppler ultrasonography and laparoscopy. These are the definitive measures for diagnosis. What is the management? For acute, the principle in the management of acute ectopic pregnancy is resuscitation because the patient is in shock. Laparotomy and not resuscitation followed by laparotomy. So it means the resuscitation should be preceded by before laparotomy, because before doing laparotomy you have to do the resuscitation. Okay, not laparotomy after resuscitation. You have to first do the resuscitation and then followed by the laparotomy because the patient is in shock and there will be hypovolemia, hypovolemic shock may be present and if at all this mass is ruptured, means the patient will have internal hemorrhage also, so that should be taken care first. So how to do the resuscitation? By applying anti-shock treatment. That is, anti-shock treatment ought to be taken energetically with the simultaneous preparation for urgent laparotomy. Ringer lactate solution should be started if necessary with venesection. Arrangement is made for blood transfusion. Laparotomy is to be done desperately. So next type is chronic ectopic. So what is the treatment? All cases of chronic or suspected ectopic ought to be admitted as an emergency. The patient is kept under observation because this mass can explode anytime. Okay, so that's why we always treat the patient as emergency. And investigation ought to be done and the patient is put up for laparotomy at the earliest at convenient time. Resumption of ovulation and contraception. About 15% of women ovulate by 19 days and about 25% ovulate by 30th post-operative day. Contraception should be ideally be commenced at the time of hospital discharge. So contraception should be taught to the mother during discharge time. And unruptured tubal pregnancy. So the management will be expected management. Observation is done hoping spontaneous resolution. Indications are in the initial serum HCG level less than 1000 international units per liter and subsequent levels of failing. If the serum HCG level is less than 1000 and it is reducing, the next readings are reducing, then we can wait for observation. And the gestation sac is less than 4 centimeter and no evidence of bleeding or rupture. So if all this criteria is present, then we can wait and watch the patient. We can observe the patient. Next is conservative management. Medical management, the indications for medical managements are hemodynamically stable. The patient should be in hemodynamically stable. Serum HCG level should be less than 3000 international units per liter. Tubal diameter should be less than 4 centimeter without any fetal cardiac activity. And there should be no intra-abdominal hemorrhage. There should not be any intra-abdominal hemorrhage. Methotrexate for systemic therapy, a single dose of methotrexate 50 milligrams per meter square is given intramuscularly, and potassium chloride should be given. Prostaglandins and hyperosmolar glucose can be given for the patient for conservative management. Conservative surgeries will be like the procedure can be done either laparoscopically or by microsurgical laparotomy. Linear salpingostomy can be done, linear salpingotomy or segmental resection or fimbrial expression can be done for in case of a conservative surgery. Linear salpingostomy means making a hole and taking out the contents. Otomy means that resection of the fallopian tube, the resection of the particular part of the fallopian tube, and segmental resection means taking out a big part of the fallopian tube, that is only one side, and fimbrial expression means we are just squeezing out the contents of the products of consumption from the from the fallopian tube to the one end of the other end of the fimbrial end. Okay, so that's called fimbrial expression. Here we will not resect or we are not going to block the fallopian tube. The pathway will remain open. Okay, so that's about the conservative surgery. Next is the interstitial pregnancy. That till now we saw about this tubal pregnancy. Next is interstitial pregnancy. Here the pregnancy occurs in the carnival or interstitial area. So the carnival region is nothing but the connecting portion between the uterine cavity and the fallopian tube. That's called carnival end. We have two carnival end on either side of the uterine cavity. Next is abdominal pregnancy. Abdominal pregnancies are rare. A primary abdominal ectopic pregnancy is a result of implantation of the fertilized ovum on the peritoneal surface. An abdominal pregnancy can be regarded as a form of an ectopic pregnancy where the embryo or fetus is growing and developing outside the womb in the abdomen but not in the fallopian tube, ovary or broad ligament. So that's called abdominal pregnancy. Now, the types of abdominal pregnancy are primary and secondary. Symptoms are excessive nausea and vomiting, constipation, pain in the abdomen, increased fetal movements. Signs will be uterine color is not well defined, Braxton Hicks contraction is absent in the abdominal pregnancy, fetal parts are felt easily, and persistent abnormal attitude and position of the fetus on repeated examination is quite common. And while abnormal high positions of the fetus is commonly found in intraperitoneal pregnancy, the fetus is lying low in the extraperitoneal pregnancy. And also, a primary abdominal ectopic pregnancy is a result of implantation of the fertilized ovum on the peritoneal surface. A secondary abdominal pregnancy forms when an embryo extruded through a rupture or abortion of tubal pregnancy. The embryo will not die because of its chorionic attachments to the uterine tube and grows by forming attachments to the pelvic peritoneum and omentum and intestine, etc. And also here the mother will have complaints of persistent lower abdominal pain, nausea, vomiting, constipation, diarrhea, distension of the abdomen and urinary frequency. There may be vaginal spotting or hemorrhage. Fetal movements are very usually painful. On examination there will be tenderness and superficiality of the fetal parts, abnormal fetal lie and loud fetal heart sounds. Ultrasonography confirms the diagnosis. Diagnosis here, when you do an internal examination, that is per vaginal examination, the uterus is difficult to separate from the abdominal mass. If it does, it is enlarged, but the cervix is not typically soft and is usually displaced depending upon the position of the sac. Imaging studies, ultrasonography and MRI can be done, and X-ray examination can be done. Management. So the delivery is by laparotomy. By separation of the placenta may be followed by major hemorrhage. The risk of continuation of pregnancy are catastrophic hemorrhage, fetal death, increased fetal malformations, increased neonatal loss. Fetal death is because of oligohydramnios, okay, and also fetal malformations or because the fetal mortality is very high. The fetal will be growth retarded and deformed in 20 to 40% of the cases due to oligohydramnios. So that the fetal mortality rate is very high, and there will be a catastrophic hemorrhage after placental separation. Okay, so if the placenta is attached to the intestine, it may be left in situ, but when the placenta is left inside, the risk of infection is high, but is considered a safe option because the separation of placenta may be followed by a major hemorrhage and increased neonatal loss. The one and best treatment for abdominal pregnancy is laparotomy. Complications of secondary hemorrhage, interstitial obstruction, infection, prognosis. Because of the risk mentioned before, the maternal mortality is less than 5%, but the morbidity is high. Perinatal mortality is approximately 90%. Perinatal means it denotes the fetal mortality. The babies, okay, neonatal mortality is approximately 90%. Fetal malformations could be as high as 50%. Normal infants have been reported in 10% of cases. So next type is the ovarian pregnancy. Ovarian pregnancy refers to an ectopic pregnancy that is located in the ovary. Typically, the egg cell is not released or picked up at ovulation, but fertilized within the ovary when where the pregnancy implants. Criteria. Spiegelberg's criteria is the diagnosis of ovarian pregnancy, or the tube on the affected side must be intact. Gestation sac must be in the position of ovary. Gestation sac is connected to the uterus by an ovarian ligament. The ovarian tissue must be found on its wall on histological examination. So these are the criteria to confirm the ovarian pregnancy. Causes are pelvic inflammatory disease, pelvic surgery, intrauterine device, and in vitro fertilization therapy. Symptoms: abdominal pain, vaginal bleeding, hypovolemia, or circulatory shock because of internal bleeding. Diagnosis: obstetric ultrasonography, pelvic examination, a unilateral adnexal marks may be found. Management: traditionally an exploratory laparotomy was performed, and once the ovarian pregnancy was identified, an oophorectomy or salpingo-oophorectomy was performed, including the removal of the pregnancy, or ovarian wedge resection can be done. The next type is the cornual pregnancy. The cornual pregnancy is a pregnancy occurring in the rudimentary horn of a bicornuate uterus, or extension in one half of a septated or subseptated uterus. So rudimentary, so it means the uterus will be two half. Bicornuate means two half uterus, and in one cornual end the pregnancy will occur. That's called cornual pregnancy, or it can be fully septated or it can be subseptated. So in all this type, if the pregnancy is occurring in the cornual end, then that's called cornual pregnancy. Symptoms: abdominal pain, vaginal bleeding, hemorrhagic shock. Diagnosis will be ultrasonography, HCG assay, and MRI. Management: surgery includes removal of the rudimentary horn. If the pedicle is short and attachment is wide, hysterectomy have to be done. The last type is the cervical pregnancy. This is rare and a variant of ectopic pregnancy. When the implantation occurs in the cervical canal at or below the internal os, then it is called as. The cervical pregnancy may be due to the rapid passage of fertilized ovum or fertilization of ovum after it reaches the cervical canal. It is rare and seldom lasts beyond the 20th week of pregnancy. The signs and symptoms includes the following. There may be painless bleeding and palpation of the cervical mass with distension and thinning of the cervical wall, partial dilatation of the external os and a slightly enlarged uterine fundus. Clinical diagnostic criteria for cervical pregnancy are soft, enlarged cervix equal to or larger than the fundus, uterine bleeding following amenorrhea without cramping pain, production of products of conception entirely confined within and firmly attached to the endocervix, a closed internal cervical os and a partially opened external os. Management will be hysterectomy. Hysterectomy is often required to stop the bleeding because of the cervix. It is occurring in the cervix. If at all the bleeding occurs in the cervix, it is difficult to manage. So hysterectomy is often required to stop the bleeding. An attempt to preserve the uterus may be made by intracervical plugging. Methotrexate therapy can be considered. Uterine artery embolism with the gel foam can control hemorrhage. Next is heterotopic pregnancy. Heterotopic pregnancy is a rare complication of pregnancy in which both extrauterine and intrauterine pregnancy occur simultaneously. So that is called heterotopic pregnancy. Causes in a heterotopic pregnancy, there is one fertilized ovum which implants normally in the uterus and one fertilized ovum which implants abnormally outside of the uterus. Diagnosis: a heterotopic pregnancy may have similar signs and symptoms as a normal intrauterine pregnancy. The blood test and the ultrasound can be used to differentiate these conditions. And heterotopic pregnancy is treated with surgical removal of the ectopic gestation by salpingectomy or salpingostomy. Expectant management has been successfully applied in selected cases. Successful salpingocentesis has been reported. Salpingocentesis means they open the fallopian tube and draining out the products of conception. So that is about the various types of ectopic pregnancy. First we saw about the tubal pregnancy. Then we saw about the interstitial pregnancy, then abdominal pregnancy, cervical pregnancy, ovarian pregnancy, and heterotopic pregnancy. The last we are going to see one journal reference, that is a study of ectopic pregnancy. It refers to diagnostic and treatment modalities. They studied which diagnostic treatment and what treatment modalities are being used maximum number of cases. Okay, which diagnostic treatment is used to detect the ectopic pregnancy very carefully, successfully done in many cases. Urine test was positive in 45 per number of the cases, and ultrasonography diagnosed complex adnexal mass in 94% of the patient, and periodic serum beta HCG done in 10 cases. And the commonest site of ectopic pregnancy was fallopian tube. It's about 96% of the cases. And salpingectomy, so that's about the diagnostic test they use. So they use the urine pregnancy test, ultrasonography, and periodic beta serum HCG levels. So the treatments are done, or salpingectomy was most commonly performed radical surgery, and medical management was successful in 66.6% of the cases. Laparoscopic management was successful in 84% of the cases. Conventional laparotomy was successful in 100% of the cases, and 74% patient had done salpingectomy, among which 20% cases were successfully managed by laparoscopy, whereas 8% were successfully managed by methotrexate. 82% of the cases required blood transfusion. So the conclusion is early diagnosis using various methods and management and treatment plan governs the outcome in case of ectopic pregnancy. So that's about the journal reference of the ectopic pregnancy. To summarize, we saw about the introduction of what is ectopic pregnancy, that is pregnancy occurring outside of the endometrial cavity. The normal place is endometrium of the uterus. Whichever pregnancy occurring outside the endometrial cavity is called as ectopic pregnancy. Then we saw various types of ectopic pregnancy, like tubal pregnancy, interstitial pregnancy, abdominal pregnancy, ovarian pregnancy, and cervical pregnancy, and heterotropic pregnancy. So that's about to summarize about the ectopic pregnancy. So if there is any doubt, you can just comment in the below, and I hope you gained some knowledge about the ectopic pregnancy, and it will be useful for your study purpose. Thank you.